Thank you, Dr. Sonu. I'm really sorry, 2 o'clock, I only have to go and start the session in the other hall. That's why I requested. Respected Chairperson Shaw sir is also here. So I'll be talking about my experience with Rena EMV. Excuse me, can you come and just help me out? Not moving. Yeah, they just escape. This is my acknowledgement. This lens collaborated with Professor Graham Barrett. So as we all know that natural crystalline lens has got a good accommodation, clear vision in the distance, clear vision in all lighting condition with a greater contrast sensitivity with a minimal aberration. So however, aging and dysfunctional lens does not compensate for the corneal aberration, but nowadays newer IOL still correcting all this. So we started with PMMA, now we are in the aspheric model. So coming to the what should be the ideal monofocal intraocular lens, it should have a clear optical quality, uncompromised vision for distance. We should compensate for the spherical aberrations to the cornea, easy to implant, PCO protection, dizzying free and less inflammation. So which is the best intraocular lens model, whether it is hydrophilic or hydrophobic, still it is a question mark. Different type of EDOF lenses available in the market. I am not going to talk about the different lenses, but what should be the effective criteria as far as the EDOF lens is concerned? Depth of focus should be plus or minus 0.5 or greater than the monofocal control, 0.2 logmar. And distance corrected intermediate visual acuity compared to the monofocal lens, it should be always superior, which achieves 0.2 logmar or better than in 50% of the eyes. And best corrected distal visual acuity always non-inferior to the monofocal control. So how is this advanced monofocal really help? Because of the different type and also with the design, with the optic size, edge profile and haptic material. Always they say that posterior edge on the posterior surface of the intraocular lens that always prevent the PCO formation. Of course, PCO is probably the most common complication of modern cataract surgery. It should be a multifactorial depending upon the either surgical technique or IOL material. But dissociation of each factor is almost impossible, difficult to differentiate in our clinical practice. Of course, one or two words about the glistening, most seen in most of the hydrophobic lenses, less incidence with the hydrophilic lenses. But what problem happens with, because these are the fluid filled microvacuoles within the IOL polymer matrix, but although visual acuity is not affected, but the contact sensitivity is reduced so much. So coming to the refractive index, always hydrophilic will be better than the hydrophobic, because hydrophobic lenses has got a more dysphotopsia. Because hydrophilic acrylic lenses are more closely mimic biological tissue due to their high water content, that is ranges between 18 to 34%. That reduces the glare and aberrations. So what should be the ideal aspheric IOL? So ideal aspheric IOL is to return the eye to a youthful optic. The young eye has got always has got a zero aspherical aberration. So coming to this particular lens, yesterday I have done the live surgery also, EMV Rayner. The advantage of this lens, it has got a aspheric anterior surface with a unique inner optic design. Always the most advantage, they induce the controlled positive spherical aberration in the center zone of the lens. So because of this blend edge, that reduces the longitudinal spherical aberration in this model. So because of there is no rings here, the reduced dysphotopsia for the patient. So normally what we can see, because of this increased spherical aberration, there is a positive spherical aberration in the center for the optic, there is a increased range of around 1.5 diopters in the emmetropic target, that we have to see. So normally patient need not have to wear the glasses for most of the intermediate lenses, intermediate vision. So coming to the other advantage, this lens, since it is a hydrophilic lenses, doesn't have any of the glistening, and you can even implant in the low silicone oil adherence, because after post vitrectomy also you can inject, since it is a hydrophilic acrylic material which has got with a low inflammatory response. So basically you can see here the advantage of this lens, average offset is only 0.08 mm 3 to 6 months after the surgery. So, and also it has got a 360 optimized PCO control on the posterior surface of the lens that prevent the PCO formation. Probably this is the only one lens, the injecting system available in the market. It comes within the whole system within the saline, so that you can take out the lens. And always I used to wonder how RayOne can do this, because unless and until they are that sure of the technology, otherwise the chances of infection will be very high. But so far not even a single patient had come with any of the problem. So since it is a hydrophilic lenses, it goes quite easily within the bag. So my first preferred choice, if the patient doesn't want to wear the glasses for distance and near, normally I check for the dominant eye. Then normally for non-dominant eye, I make myopic by around 0.5 to 0.75 diopter, so that patient will have 6.6 for the distance when they open both the eyes, and N5 for the near. This is about the injecting system. That's what I used yesterday. Straight away, like you take out the whole including injecting system with the lens, take out, put the viscoelastic within the small hole inside, then it can even go through 2.2 quite easily. And very, very easy to inject, and central channels are very good. It has come with now toric platform too. These are few of the studies compared with some of the other lenses available in the market, but definitely it shows a more advantage over the other lenses. So we have operated around 300 eyes with EMV, with the 50 eyes with the toric. Both the lenses have given exceptional results. More than 98% have got a comfortable monocular distance 6.6, and 95% are having intermediate vision N12 at 40 centimeter. None of these patients really presented with glare, starburst, halos at the end of 90 days. None of the patient had any residual toric refraction after usage of toric EMV. Patient were fully corrected in the dominant eye and non-dominant, and made myopic by 0.5 diopter to gain the emmetropia. All 300 eyes were 95% emmetropic. In conclusion, these newer monofocal lenses are to be marketed as a premium monofocal lenses, as Ajay told in his talk. So they give a good intermediate vision and near vision. Added advantage of no halos, glare, shadows provide better results as an advanced monofocal. RayOne 1 EMV toric is a promising intraocular lens on the same rotational stable platform. I thank again my brother Sonu to give me opportunity to go a little early than other people, and you all invited to COSCON 2024, which is going to be held in Udupi. Thank you.
Thank you, KP, for that wonderful insight. I think this is one lens which is very close to your and Graham Barrett's heart. It's his product, I think.
Yeah. Because see, I've been doing this Press Beyond. I think Sheetal is also here. The same concept, how Press Beyond is working, similar kind of concept this lens is also going to work. So in the end, none of the patient, even when I'm doing Press Beyond, nobody complained any glare and halo, sir. They are not going to close each eye and see. So similar kind of concept I am putting in the IOL platform. The results are same only.